Hi everyone. My name's Ariel. I'm a TA for Intro to Psychopathology, and this is the review for Midterm 3 that's happening tomorrow. So there were no questions that were posted on my courses, and so I'll just be answering any questions you guys have right now. To whoever's watching, you can post questions, I think, on the chat option here. And yeah, so post your questions there if you guys have any. And so I'll just be waiting until I get some of those. And also let me know if the volume or the audio or visual things are not working, because, yeah, just so I know. Okay. So we have a question: which cluster for person? Okay. So we have a question: which cluster for? Sorry. So I'm just trying to get access to the question without having to open the link to the video, which replays my audio back at like a delay. Sorry, it'll just be 2 seconds. Okay. Okay. So the question is, which cluster for personality disorders seek treatment the most? Is that something that was covered in class? I'll just double check my notes because I don't remember if Dr. Weinberg talked about different treatment-seeking rates between 3 clusters, but I can check. Or if it was something that was in the textbook and you want me to go over. Let me just check the textbook. So I don't have that. Oops. I know she said in class. She said in class, but in the textbook it says cluster B. So much more likely you see help than other clusters. Okay, so if there's any discrepancies in what Dr. Weinberg says and what the textbook says, I would say go with what the information that Dr. Weinberg gave, considering that she's the one preparing the exam. But if you can point me to what page it says cluster B for the textbook, I can check. Um, um, so I'll just double check. Um, okay. So to whoever asked that question, I can't seem to find it in the notes, but if you can bring to me the page that talks about the difference in treatment seeking, then you can compare. But if the information is discrepant between the two sources, I would say go with what Dr. Weinberg mentioned in class. But I can definitely help with any sort of conceptual issues or questions that you guys might have, or outcomes of certain studies from the textbook or from the lecture. Okay, so I have a question for the lecture on schizophrenia. Could you explain the study on slide 54? Okay, I'm just going to pull up that slide. Slide 54. Okay, the dopamine synthesis one. Okay, let me just pull that up. Okay, so basically, they were testing the functional. They wanted to see if there is differences or deficits with schizophrenic patients compared to healthy controls, whether there's a difference in or whether there are working memory deficits. And so basically they had the so the participants would have a screen in front of them, and they would see an object, sort of like a target, in a certain location. And then there would be a distractor task that they would have to do. And then afterwards, they would go back and be asked, and were asked, in what location was the target that you did in the task before. So it requires them to keep in mind the information of the location from the previous task while they're doing the distractor task. And so they want to see were participants able to keep that location in mind. And so they found that schizophrenic patients had did significantly worse at the task. So they had much more difficulty remembering the location of the object after the distractor task, whereas for other populations, it would be pretty easy to remember the location and point it out. And so they found that this effect when schizophrenic patients, so when they were ill and when in remission, and so that was later studies, sorry. So they found that these deficits in working memory generalize to patients who are in remission, and also those who have, or relatives of those who have schizophrenia. But that was found after the principal study. Does that answer the question, Julienne? If not, I can explain it again. Okay. So in the meantime, if any part of that was unclear, I can. Oh, okay. It was good. Okay, cool. So Erica, you pointed out the page. Thank you. So I'm just gonna get that out. So in the textbook, it says that cluster B, or patients are with disorders from cluster B, sought out treatment at a higher rate, whereas Dr. Weinberg said it was cluster C, if I understand right. So I would say go with what let me just check. So I would say cluster. Sorry, I'm just double checking one thing. So it's a tough one with so if since there is confliction with what was said in class and what was in the textbook, I can double check with Dr. Weinberg and the grad students to clarify that, because if the textbook, it says that cluster B patients seek treatment the most, but cluster B also includes things like antisocial personality disorder, which we know from in class that treatment-seeking rates are lower with that disorder just because they don't feel distress themselves. So I would I'll check with Dr. Weinberg to clarify, but if there was ever any question on the test where there the different options for an answer conflict in terms of what the textbook said is right or what Dr. Weinberg said is right. If there's conflict, then it would probably give the right or give the right answer to both, because there is evidence for both in terms of what was taught in the textbook and the lecture. So odds are that won't happen, but I'll clarify about that point specifically about the treatment question. So yeah, let me know if that's good. So I'll do that, and I'll post on the discussion page for midterm 3, and I'll let you guys know. Any other sort of clarifications or conceptual things? I'll just wait to see if a question pops up or anything. So in her lecture slides on antisocial personality disorder and psychopathy, she talked about etiology. Does the etiology apply to both disorders? So let me double check. I don't think she separated etiology by antisocial and psychopathy. I could be wrong. I'll double check because they do have different different symptoms, or not symptoms, but different criteria in terms of diagnoses. But for the etiological causes, actually, well, well, in terms of, so what I have in my notes is that when talking about psychopathy, the etiological factors that were talked about are prenatal and birth complications, and also genetics in terms of twin studies and rates of psychopathy. And then with antisocial personality disorder, they talked about etiology in terms of the MAOA, so the breakdown of neurotransmitters, and predictors like delinquency. So she does separate them in terms of etiology, but then remember that psychopathy is sometimes considered as a subset of antisocial personality disorder. So oftentimes people with or a lot of people with psychopathy will also be antisocial or meet criteria, but not the inverse. So psychopathy is sort of a subtype. So they do have common etiology in terms of like genetics and like the twin studies that were talked about, but there are sort of separate factors in terms of each, because she does go into etiology for one than the other. If that makes sense. Any follow-up questions about that, about etiology of psychopathy or anything else about antisocial personality disorder or personality disorders in general? So just to clarify, were you talking about any sort of specific etiological factor and whether it applies to both antisocial personality disorder or psychopathy? Or did you mean in general? Just to make sure I understood the question. Oh, okay. I didn't say which ones applied to antisocial personality disorder or psychopathy. Okay, so I'm looking back. Okay, so I'll answer the first question first. So if I understand correctly, Dr. Weinberg went into etiology separately for psychopathy and antisocial personality disorder. So let me just check the PowerPoint super quick. So in terms of genetics, she goes into antisocial personality disorder particularly. And then for the MAOA gene, she doesn't talk about. Okay, so she seems to talk about to not make the differentiation within the studies. So for example, with the MAOA gene study, she doesn't talk about either antisocial personality disorder or psychopathy specifically. So you can assume that these etiological factors encompass both, unless she makes the distinction. which makes sense because psychopathy is considered a specific subtype or of psychopathy. And so etiological factors can apply to both. So unless she specifies the difference, then you can assume that the factors apply to both. And so the next question, about the role of the MAOA gene. Okay, so, or the MAOA, yeah, the MAOA gene. So basically, the gene that produces monoamine oxidase. Basically, it helps degrade or break down neurotransmitters like dopamine, norepinephrine, and serotonin. And so, because it breaks these neurotransmitters down, the more MAOA you have, the less neurotransmitters you have, because there's more of the the more MAOA there is, the more neurotransmitters are being taken away or broken down. And so the hypothesis or the theory is that wait, I just want to make sure I get this right. So low levels of MAOA are associated with those who are higher on antisocial antisocial personality disorder. But if you remember, also there's the diathesis, so that the effects of MAOA on increasing someone's risk to show antisocial behaviors interacts with maltreatment. So there was the graphing class, I don't know if you guys remember, but only at high levels of maltreatment do you see the effect of MAOA being associated with more antisocial behaviors. Yeah, so let me know if that makes sense, or if that's what you were looking for. Let me just see if I missed anything. Okay. Okay, cool. Next, someone asked, so does a person with antisocial personality disorder, upon first encounter, show more abnormal behavior? With antisocial personality disorder, they won't necessarily show abnormal behavior because basically how antisocial personality disorder is diagnosed, or the criteria for it, is mostly behavioral. So things like callousness, disregard for others' feelings, etc. So they're very manipulative. So at first glance, they might not seem, or they'll put on an act of someone normal in order to manipulate others to get what they want. So I'm pretty sure somewhere they talked about how there were higher rates. Oh yeah, prevalence of antisocial personality disorder, higher in criminal settings and higher in hospital settings, so like doctors. And so it's unclear why there would be a higher rate of antisocial personality disorder in the medical field. But that, I think, goes to show that antisocial personality disorder may not be visible as abnormal on first glance. they can be high functioning. So they talk about oftentimes about like sort of CEOs of like big companies who may be swindling people or fraud or taking people's money. And maybe they show all the same things like callousness that would get you diagnosed with antisocial personality disorder, but they wouldn't seem abnormal to society, if that makes sense. Yeah. So, yeah, it's not always, I would say antisocial personality disorder is not always manifested as sort of like the criminal. So, the criminal aspect of it. There's like non-critical antisocial personality disorder. So this aspect is similar to psychopathy. I'm having trouble distinguishing the two. Okay, so basically, psychopathy, so antisocial personality disorder encompasses a lot of, is behavioral based. So if you have the full list in the PowerPoint, I'm just bringing that up. So, oops. Feels normal. Yeah, so antisocial personality disorder involves behaviors like deceitfulness, impulsivity, irritability, and aggressiveness. Whereas psychopathy encompasses more emotional facets. So there's things like superficial charm or lack of remorse or shame. So it's often said that psychopathy is sort of a subset of antisocial personality disorder. So for example, in the criminal setting, they see a lot of people with antisocial personality disorder because one of the behavioral criteria is a sort of things that can so like criminal things that can lead to criminal behavior, like disregard for other safety, failure to conform to social norms or lawful behaviors, whereas psychopathy is sort of a subset where there's the addition of sort of these emotional factors like lack of remorse, or lack of empathy, things like that. So psychopathy is sort of a more specific factor that more, I guess, specific group that encompasses both behavioral and emotional and interpersonal factors. So I don't know if that helps you piece the two apart. So both of them are definitely related. In fact, most people who meet the criteria for psychopathy also meet criteria for antisocial personality disorder, but not the inverse. So there are specific features of psychopathy that you won't find in antisocial. Okay, that answered your question. Good. So yeah, if anyone else has any questions, feel free to put them down. We have like half an hour left. So we've gone over bits of antisocial personality disorder, some questions about schizophrenia, or no, we didn't. So if there's any questions about schizophrenia, since that's some recent material, or alcohol use disorder, or borderline, yeah, you guys can ask those. Okay, the study on expressed emotion in schizophrenia. Sure. Um, so let me just pull that up. Um, okay. Okay. So basically, during the mass deinstitutionalization of psychiatric wards in the United States, there was a lot of schizophrenic patients who had to leave the ward, and so some would go back to their family, and some were living alone, whether so with not with their family, and they found in terms of the course of the illness, those who went home to their families did worse than those who lived alone. And so the reason for that, they think, is because of expressed emotion. So basically, family members would answer or would interact with the patient with a lot of criticism and hostility, especially when the schizophrenic patient would say something odd or have an odd behavior. And so they did some follow-up studies on that. Let me just see. Pull those up. So the Rosenfarb al. 1995. So that one looked at. Okay, so they looked at what. So levels of mood, negative mood, and odd or disruptive behaviors in the patients with families with high or low levels of expressed emotion. So they found whether so patients who with families that were either high or low on expressed emotions both had similar levels of negative mood. So the the expressed emotion wasn't causing patients to have higher negative mood than um, uh, other patients with families low on expressed emotion. But it was where expressed emotion was what it was associated with were the odd or disruptive behaviors. Um, families expressing high EE were associated with patients having more odd behaviors. And how Dr. Weinberg explained that was that if a patient says something odd, I don't know, like a hallucination that they're having, and then a family member responds by either by saying, "Oh, that's not true," or "You're responding in some critical manner or invalidating how they're what they're experiencing or what they're saying, then that causes the patient to dig in even more to that belief or that idea, and so express that odd behavior again, like, no, this is what I'm for hallucination, this is what I'm seeing. So it really causes them to the criticism and the hostility causes them to become, I guess, more strongly attached to those behaviors, and as a consequence, they'll express them more. And then there was the next study. Um, um, okay, so I think this goes off of the previous one. So this is again Rosenfarb, the one with the line graph. So in patients with families who are low on expressed emotion, if they experience or if they show an odd behavior, or in this case it was an unusual thought, uh, then the family is not more likely to get to criticize, and so there's the increase. So there's no sort of increased criticism, whereas in the families with high on expressed emotion, already there's an increased likelihood, even prior to the unusual thought, for families to express criticism. But that increases even higher as a consequence of the unusual thoughts or behaviors that the patient's having. Um, so it's an interaction effect in terms of families high on EE are more critical and hostile in general, but especially even more so in response to a schizophrenic patient's odd thought or behavior. Um, I think those were the 3 studies on expressed emotion. But if you have a question about any one of them in particular, let me know. Cool. So I think, so we haven't covered, oh, okay. Could you explain how cannabis can predict the onset of schizophrenia? Okay. So I'm just gonna pull that up. Okay. Oops. Okay. So, so cannabis, or the main ingredient, or one of the key ingredients in cannabis, is THC. And so THC causes higher dopamine levels in the system after consumption. And we know that dopamine plays a role in schizophrenia. So it was mentioned, I think, previous or earlier on in these lecture slides, that they think that schizophrenia is characterized by higher levels of dopamine in the striatum and lower levels in the frontal cortex. So there's a dopamine dysregulation, it seems, present in those with schizophrenia. And so cannabis playing a role, or modifying the dopamine levels in the body is thought to increase the likelihood of schizophrenia in those who are already vulnerable. So we have, okay, so there was this study. So the study with the brain volume changes. So it's the one with the little like scatter plot of dots in terms of change in gray matter. Um, so so you have healthy controls. So you have healthy controls, patients or schizophrenic patients who don't use cannabis, and those who do. And so there's more or less a decrease in gray matter in all three groups. But in those in patients who use cannabis, there's an even larger decrease in gray matter. So basically, what they're thinking is that in those who have a vulnerability to develop schizophrenia, whether it be because of genetic or all of the different causes in the multiple hits model. So if someone's vulnerable, then the consumption of cannabis is sort of so that cannabis's effect is more likely to sort of tip them over the edge to developing schizophrenia, if that makes sense. But not just anyone who consumes cannabis, but just it seems to have a particularly devastating effect for those who are already vulnerable to it. So it predicts the onset of schizophrenia in terms of the population who's already vulnerable. Does that answer your question? Let's see if there's any other studies that she talked about. in relation to that. Oh yeah, and so okay, cool. And just one more thing, the effects of cannabis on those who are vulnerable to schizophrenia, the effects are particularly strong in adolescents. Um, um, uh, yeah, yeah. Mm. Okay. So we don't. So there's about 7 minutes left to the review session. So if you guys have any more questions, you can put them here, whether it's like a clarification of the other things I talked about, or anything about like borderline personality disorder or alcohol use disorder, since I don't think I touched on those. And yeah, so if you guys have any questions after the review session's over, you can send them to the TA email address, and they should be able to um, get back to you before the midterm tomorrow afternoon, probably. Um, yeah, if you guys think of any other questions after this. So, are there any last minute questions? Otherwise, um, I'll close the review session for the day. Um, okay. Well, so I guess there aren't any questions. So thank you guys for listening to the review session and for your questions. I hope it was helpful, and good luck on the midterm tomorrow.